Effective medications for improving ejection fraction, EF, in heart failure, updated for 2025 consensus. Heart failure with reduced ejection fraction, HFrEF, is a condition where the heart muscle is weakened and cannot pump blood efficiently, leading to a low ejection fraction, EF. In the current 2022 AHA/ACC/HFSA guideline for the management of heart failure, still the most recent full update as of November 2025, and the 2023 to 2025 ESC-focused updates, HFrEF is defined as LVEF less than or equal to 40%. This is the threshold at which all four pillars of therapy are strongly recommended, Class 1, Level A, 2. No major revisions to HFrEF management have occurred in 2025. Recent AHA/ACC updates focus on core guideline principles, cost/value methodology, and HFpEF advancements, but the four-pillar Guideline-Directed Medical Therapy, GDMT, for HFrEF remains unchanged. The primary goal of modern treatment is to promote reverse cardiac remodeling, a process where the damaged heart muscle heals, shrinks back toward normal size, reduces wall stress, and regains pumping strength, thereby increasing EF and improving survival. This can lead to HFimpEF, heart failure with improved EF, a new classification in the 2022 guidelines for patients whose LVEF rises above 40% on therapy. Clinical guidelines have established a four-pillar regimen, known as GDMT, that collectively provides the most powerful strategy for achieving this improvement in EF and reducing mortality. Achieving the maximum EF improvement and survival benefit requires the synergy of all four drug classes working together. 2. Recent 2025 AHA/ACC statements emphasize the cost-effectiveness of GDMT, with value statements highlighting high-value therapies like SGLT2 inhibitors for broad implementation. The four pillars of EF improvement, the cornerstones. The four classes of medications that form the core HFrEF treatment are designed to interrupt the hormonal cycles that damage the heart and amplify the body's natural healing mechanisms. ARNI, angiotensin receptor neprilysin inhibitor, the powerhouse. Medication example, Entresto, sacubitril/valsartan. Mechanism of EF improvement. Entresto offers a dual-action benefit that is superior to older therapies like ACE inhibitors or ARBs. Valsartan, ARB component blocks the harmful effects of the renin-angiotensin system, RAS, which causes blood vessels to constrict and promotes cardiac scarring, fibrosis. 3. Sacubitril, neprilysin inhibitor component. This component prevents the rapid breakdown of the body's natural, protective hormones called natriuretic peptides, NPs, like ANP and BNP. By blocking the breakdown of these beneficial peptides, sacubitril boosts the heart's natural defense system. 3. Role in EF. It is considered the most powerful single agent for promoting reverse remodeling and is the first-line choice for EF recovery, with clinical trials, e.g., PROVE-HF, showing a significant absolute median increase in EF, e.g., from 28.2% to 37.8% after 12 months. 4. No single agent from any other class has demonstrated as large or consistent an EF increase in head-to-head or mechanistic studies as ARNI. This is why guidelines give ARNI a Class 1, Level A recommendation as the preferred foundation of therapy, stronger than ACEI or ARB alone. Intolerance and angioedema risk. The sacubitril component, by inhibiting the enzyme neprilysin, can indirectly increase levels of the substance bradykinin. Elevated bradykinin can cause blood vessels to widen and leak fluid, leading to the risk of severe swelling known as angioedema, swelling of the face, lips, tongue, or throat. This risk is the primary reason why a patient may not be able to tolerate an ARNI, necessitating a switch to an alternative therapy. Beta blockers, the rest and repair agent. Medication example, carvedilol, or metoprolol succinate, extended/controlled release, bisoprolol. Mechanism of EF improvement. In HFrEF, stress hormones, like adrenaline, are chronically overproduced, which is toxic to the heart muscle. Beta blockers slow the heart rate and block the detrimental effects of these stress hormones. This allows the heart muscle to rest, reduces its oxygen demand, and stabilizes its electrical system. 5. Role in EF. They are essential for sustained long-term recovery and remodeling, allowing the heart to structurally heal and improve function. 5. Only these three beta blockers, carvedilol, metoprolol succinate, and bisoprolol, are considered evidence-based for mortality reduction and reverse remodeling in HFrEF. Other beta blockers, e.g., atenolol, metoprolol tartrate immediate release, nebivolol, do not have the same level of evidence and are not recommended as first-line in guidelines. 2, 5. MRA, mineralocorticoid receptor antagonist, the anti-scarring agent. Medication example, spironolactone or eplerenone. Mechanism of EF improvement. These drugs block the hormone aldosterone, which contributes to stiffening and fibrosis, scar tissue formation, in the heart muscle. By counteracting aldosterone, MRAs actively prevent long-term structural damage and help preserve the integrity of the pumping chambers. 6. Role in EF. They prevent the heart muscle from becoming stiff and scarred, securing the functional improvements driven by the other medications. To achieve the mortality and remodeling benefits seen in trials, RALS and emphasis HF, target doses are spironolactone 25 to 50 mg daily or eplerenone 25 to 50 mg daily, with close monitoring of potassium and kidney function. 2, 6. SGLT2 inhibitors, the cardioprotective regulator. Medication example, Jardiance, empagliflozin, or Farxiga, dapagliflozin. Mechanism of EF improvement. This is a newer cornerstone therapy, now mandatory due to its profound cardiovascular benefits shown in trials like DAPA-HF and EMPEROR Reduced. 7, 8. They reduce strain on the heart by causing the excretion of excess sodium and water via the kidneys, reducing volume and pressure, preload. They provide direct cardioprotective effects, including improving the heart's energy metabolism and reducing inflammation and cardiac strain. 7. Role in EF. They reduce strain and provide cellular-level protection, supporting the entire remodeling process. The cardiovascular and heart failure benefits are considered a class effect, so either dapagliflozin or empagliflozin, and in many countries sotagliflozin, can be used. Benefits are seen even in non-diabetic patients and appear early, within weeks. Achieving the full benefit of guideline-directed medical therapy, GDMT, requires initiating the medications at a low dose and titrating them up to the target dose used in the major clinical trials. This titration process is critical for maximizing both EF improvement and survival. 2. Pillar. Medication example. Clinical trial. Target dose, TD/maintenance dose. Key titration notes. ARNI. Entresto, sacubitril/valsartan. Paradigm HF, free, 4. 97/103 mg twice daily, BID, total daily dose, 194/206 mg. Start low, e.g., 49/51 mg BID, and double the dose every 2 to 4 weeks, as tolerated by blood pressure. The trial dose provided maximal benefit. 2. Beta blocker. Metoprolol succinate, ER. Merit HF, 5, 14. 200 mg once daily, QD. Start very low, e.g., 12.5 to 25 mg QD. The TD of 200 mg QD was proven to significantly reduce mortality in the trial. 14. Carvedilol. US carvedilol, 5, 14. 25 mg BID or 50 mg BID. TD is 25 mg BID for patients under 85 kg and 50 mg BID for those over 85 kg. 14. Bisoprolol. Seebees 2, 5. 10 mg once daily, QD. Titrate slowly, e.g., double dose every 2 weeks, to avoid worsening heart failure. 2. MRA. Spironolactone. RALS, 6, 15. 25 mg to 50 mg once daily, QD. The landmark RALS trial used a mean dose of 26 mg daily, with an option to titrate up to 50 mg daily, 6, 15. Eplerenone. Emphasis HF, 2, 14. 50 mg once daily, QD. Target dose is 50 mg QD if renal function and potassium are stable, 14. SGLT2 inhibitor. Jardiance, empagliflozin. Emperor reduced, 7, 16. 10 mg once daily, QD. No titration required. The dose of 10 mg QD was the standard fixed dose in the pivotal trials, 7, 16. Farxiga, dapagliflozin. DAPA-HF, 8, 16. 10 mg once daily, QD. No titration required. Benefits are seen early at this dose, 8, 16. The primary goal of modern treatment is promoting reverse cardiac remodeling, and this benefit applies across all major etiologies of HFrEF, including heart failure caused by cholesterol-related blockage, clinically termed ischemic cardiomyopathy, ICM. Does Entresto treat EF reduction caused by cholesterol blockage? Yes, Entresto is a mandatory Class 1, Level A therapy for improving EF and reducing mortality in HFrEF caused by cholesterol blockage, ischemic cardiomyopathy, 2. Component. The coronary artery blockage, the cause. The resulting heart failure, the damage. Problem. Cholesterol deposits physically narrow the arteries, leading to prior heart attack and scar. The heart muscle is weakened, leading to low EF. Treatment. Statins, e.g., rosuvastatin, and procedures, stents/surgery. The 4 pillars, including Entresto. Entresto's role. None. It does not dissolve cholesterol or open blocked arteries. Major. It blocks neurohormonal damage, valsartan, and boosts healing peptides, sacubitril, promoting reverse remodeling and improving the EF of the remaining viable heart muscle. 3. Guideline consensus. The pivotal paradigm HF trial and the resulting guidelines, 2022 AHA/ACC/HFSA, establish Entresto as a foundational therapy for all eligible HFrEF patients, including the 60% of the trial population who had ischemic heart failure. The benefit of Entresto comes from healing the remaining viable heart tissue that is chronically weakened by the disease process, thus raising the overall EF. 4, 13. Do Jardiance and Farxiga improve EF the same way? Yes, they work the same way overall. Both are SGLT2 inhibitors and deliver comparable cardiovascular protection and reverse remodeling in HFrEF, making them fully interchangeable per guidelines. SGLT2 inhibitors as a class improve LVEF by 2 to 5% on average in HFrEF over 6 to 12 months, driven by reverse remodeling, e.g., reduced left ventricular volumes and mass. Aspect. Dapagliflozin, Farxiga. Empagliflozin, Jardiance. Direct comparison/notes. Typical EF increase. Plus 2% to plus 4.5% at 6 to 12 months. Plus 3.5% to plus 6% at 6 to 12 months. Empagliflozin shows slightly larger absolute EF gains in most comparisons, 1-2% absolute. Primary trial EF data. DAPA-HF, 2-3% LVEF increase at 8 to 12 months, greater gains in non-ischemic HFrEF, 8. EMPA reduced, 2.5-4% LVEF increase at 6 to 12 months, plus 10 ml reduction in LV end diastolic volume, 7. No head-to-head RCT, pooled meta-analysis shows consistent class effect. Meta-analyses. Network Meta, 2022 comparable to empagliflozin for HF outcomes, no significant EF difference. Broader SGLT2I Meta, 2022, N equals 21, 947 23% reduction in CV death/HF events. Similar, 2020 Meta of DOPA-HF plus EMPA reduced, consistent renal/CV benefits, implying equivalent remodeling. 2023 Meta, SGLT2I in HFrEF no between drug differences in EF gains, benefits independent of baseline EF, diabetes, or EGFR, 12. Observational/retrospective studies. Smaller EF gains 3-4% at 6 months, versus empagliflozin in one study, N equals 233, 2022. Registry, 2024, N equals large similar CV outcomes but potentially less symptom improvement. Greater EF increase, 5-6% at 6 months, and better NYHA class reduction in same study. A study showed empagliflozin associated with slightly lower composite mortality/hospitalization versus dapagliflozin in a real-world setting, 17. 2022 retrospective, N equals 233 empagliflozin superior for EF, plus 1 to 2% absolute, LV diameter, and NT-proBNP. Limitations, retrospective bias, small samples. Guideline view. Equivalent, start low dose, 10 mg daily, and titrate. Benefits seen early. Equivalent, same dosing. Slight edge in ischemia subgroups per post hoc. 2022 AHA/ACC/HFSA, no distinction, class effect for remodeling. 2023 to 2025 ESC, both, strongly recommended, without preference, 2. Bottom line on SGLT2I choice, 2025 consensus both Class 1, Level A, start one as soon as possible. No guideline prefers one over the other. Real-world registries and retrospective comparisons slightly favor empagliflozin for magnitude of EF recovery and symptom improvement, but differences are small, 1-2% absolute. Choose based on cost, insurance coverage, patient preference, or comorbidities. The synergy of all 4 pillars far outweighs the minor differences between the 2 SGLT2 inhibitors. 2025 AHA/ACC value statements underscore SGLT2I as high-value, cost-effective additions to GDMT. Losartan is an angiotensin receptor blocker, ARB, a medication that blocks the harmful RAS. Trials like the HEAL study confirm that ARBs, as a class, are effective in reducing heart failure hospitalizations and mortality, a benefit that stems from reverse cardiac remodeling and EF improvement. 9. Current guideline status, 2022 AHA/ACC/HFSA and 2023 to 2025 ESC focused updates. Losartan is now generally considered an alternative therapy for HFrEF, not the preferred first-line option. 2. ARNI is strongly preferred, Class 1. ACE inhibitors or ARBs, including losartan, are now downgraded to acceptable alternatives only if ARNI cannot be used, e.g., cost barriers in some regions, symptomatic hypotension, or rare allergy/intolerance to sacubitril, such as angioedema. When an ARB is chosen, losartan, valsartan, or candesartan are the best studied options. When it is used, losartan is typically prescribed only when a patient cannot tolerate the preferred drug, Entresto, due to specific side effects or contraindications. Why Entresto is preferred? While losartan and Entresto both address the RAS, Entresto's sacubitril component provides a superior benefit due to its added power in boosting the body's protective peptides. No single drug in any other class is considered as effective as Entresto in promoting EF improvement, though the greatest benefit comes from using all four pillars together. Hydralazine/isosorbide dinitrate, HSDN, the vasodilator alternative. Hydralazine/isosorbide dinitrate, HISDN, is an older, distinct, and highly effective combination therapy that acts as a direct vasodilator, blood vessel opener, rather than a neurohormonal blocker. It reduces the work the heart must perform, decreasing both preload and afterload. Mechanism: isosorbide dinitrate reduces preload, volume returning to the heart, via venous dilation. Hydralazine reduces afterload, resistance the heart pumps against, via arterial dilation. Role in GDMT. HISDN is not one of the four pillars for all patients, but it holds two crucial guideline roles. Indication. Guideline recommendation. Key context. Additive therapy. Class 1, strong, 2, 18. For Black/African American patients with symptomatic HFrEF, NYHA class 3 to 4, who remain symptomatic despite receiving optimal GDMT, 4 pillars, based on the HFT trial, 18. Substitute therapy. Class 1, strong, 2. For any patient who has a confirmed contraindication or intolerance to the preferred pillar 1 agents, ARNI, ACE inhibitor, or ARB, such as a history of angioedema. What about statins, rosuvastatin, atorvastatin, etc., and EF improvement? Cholesterol buildup worsens EF. Rosuvastatin help reduce cholesterol buildup. Statins are used for secondary prevention of atherosclerotic cardiovascular disease, ASCVD, not for improving the ejection fraction in established HFrEF, 10, 11. Clinical situation. Does high-intensity statin meaningfully improve EF in established HFrEF? Evidence, November 2025 View. Primary prevention. Yes. Prevents first MI, prevents EF drop. Recent acute MI, even if EF already low. Yes. Prevents reinfarction, limits further EF drop, for S, care, prove IT, TNT, etc. Chronic stable ischemic cardiomyopathy, old scar. No. Scarred muscle does not regenerate. Established HFrEF, any etiology, ischemic plus non-ischemic. No clinically relevant gain. Corona, GCHF, 2019 to 2024 metas, 10, 11, 12. Landmark RCTs of rosuvastatin exclusively in systolic heart failure patients. Trial. Year. N. Baseline LVEF. LVEF change on rosuvastatin 10 mg. All-cause mortality. Keynotes. Corona, 10. 2007. 5011. 31%. Is almost equal to 0% at 3 years. Neutral, HR 0.95. Fewer HF hospitalizations, but no EF benefit. GCHF, 11. 2008. 4,574. 33%. No significant change. Neutral, HR 1.00. Safe, but no remodeling benefit. Meta-analyses, 2019 to 2024, 12. Greater than 12,000 HFrEF patients. 28 to 35%. Plus 0.5% to plus 1.5%, statistically detectable in some pooled analyses, but clinically trivial. Neutral, HR 0.92 to 1.00. High heterogeneity, no mortality benefit in RCTs. Despite 40 to 50% LDL-C reduction, these trials show virtually zero meaningful rise in ejection fraction. Statin dosing for secondary prevention in HFrEF, ASCVD. For patients with HFrEF caused by cholesterol blockage, ASCVD, high-intensity statin therapy is strongly recommended, Class 1, for secondary prevention of new ischemic events, such as heart attack or stroke. 2. The treatment goal is to reduce LDL-C by greater than or equal to 50% from baseline. Statin medication. Target high-intensity daily dose. Expected LDL-C reduction. Atorvastatin. 40 mg to 80 mg once daily, QD. Greater than or equal to 50%. Rosuvastatin. 20 mg to 40 mg once daily, QD. Greater than or equal to 50%. The dose should be titrated to the maximum tolerated high-intensity dose, e.g., 80 mg atorvastatin, to maximize the cardiovascular risk reduction. 2. 2025 Guideline Position on Statins in HFrEF. Scenario. Recommendation for high-intensity statin, rosuvastatin 20 to 40 mg, atorvastatin 40 to 80 mg, etc. HFrEF plus documented atherosclerotic cardiovascular disease, ASCVD, prior MI, stents, CAD, stroke, PAD. Strongly recommended, Class 1, for secondary prevention of new ischemic events. 2. Pure non-ischemic HFrEF, viral, peripartum, idiopathic, etc. Not indicated for EF improvement or mortality reduction. Very advanced cachectic HF with already low cholesterol. Reasonable to deprescribe, avoids polypharmacy, zero proven benefit. Bottom line in 2025, the 4 pillars are the only therapies that reliably raise EF and extend life. Statins are not a 5th pillar. Use rosuvastatin only when there is a separate atherosclerotic indication, and use the high-intensity target doses listed above. Therapy. Substantively improves EF. Proven mortality reduction in HFrEF. Required in almost every patient. Notes. RNI. Plus 5 to 10%. Yes. First line. Treats HFrEF of all etiologies, including ischemic. 2. Beta blocker. Plus 4 to 8%. Yes. Yes. Only 3 agents, carvedilol, metoprolol succinate, bisoprolol. MRA. Plus 2 to 6%. Yes. Yes. Antifibrosis/anti-scarring agent. SGLT2I. Plus 2 to 6%. Yes. Yes. Equivalent, Jardiance/Farxiga, benefits early. HSDN. Plus 2 to 4%. Yes, in specific groups. Only if specific indications met. Substitute for ARNI/ACEI/ARB intolerance or add-on for Black patients. 2-18. High-intensity statin. 0 to 1.5%. No. Only if ASCVD present. Treats the cholesterol blockage, not the resulting EF failure. 10-11. Start and titrate the 4 pillars first. Add a high-intensity statin only if atherosclerotic disease is present, targeting the high-intensity doses of atorvastatin or rosuvastatin. Term. Simple definition for patients. Angioedema. Severe swelling, a rare but serious side effect of certain heart medicines, like Entresto or ACE inhibitors, that causes swelling, typically in the face, lips, tongue, or throat. Requires immediate medical attention. ASCVD. Atherosclerotic cardiovascular disease, disease caused by the buildup of cholesterol, plaque, in the arteries, leading to problems like heart attacks and strokes. Bradykinin. Swelling hormone, a natural body chemical that, when allowed to build up too much, as with certain heart medicines, can cause the blood vessels to leak fluid, triggering angioedema. Ejection fraction, EF. Pumping strength, the percentage of blood that the heart pumps out of the main chamber, left ventricle, with each beat. An EF $/low 40% is considered heart failure with reduced EF, HFrEF. Fibrosis. Scarring, the development of stiff, non-working scar tissue in the heart muscle, which is a key contributor to the heart losing its ability to pump effectively. GDMT. Guideline-Directed Medical Therapy, the specific combination of medications, the 4 pillars, that have been proven in large clinical trials to be the most effective for treating heart failure and extending life. HFrEF. Heart failure with reduced EF, the medical diagnosis for when the heart's pumping strength, EF, is low, $/low 40%. LDLC. Bad cholesterol, low-density lipoprotein cholesterol, which contributes to the plaque buildup that causes heart disease, ASCVD. Neurohormonal blockade. Hormone shut-off, the main strategy of heart failure medicines, like ARNI, ACE inhibitors, ARBs, to block the overproduction of stress hormones, like adrenaline and aldosterone, that harm the heart muscle over time. Reverse cardiac remodeling. Heart healing, the process where the heart muscle begins to heal, shrink back toward a more normal size and shape, and regain pumping strength, increase EF, as a result of taking heart failure medication. Titration. Gradual increase, the process of slowly increasing the dose of a heart medication over several weeks or months to reach the maximum effective and safest dose tolerated by the patient. Vasodilator. Vessel opener, a drug that directly widens, dilates, blood vessels to reduce the pressure and resistance the heart has to pump against, making the heart's job easier. References.